Let's talk about a call that we had on the 29th of March of this year. A call at about 6:20, 6:26, I believe, in the morning is when originally the call came out. We were called to a residential care facility, more like a post-acute rehab facility is what this patient was actually there for. And as I said, about 6 o'clock in the morning, 6:20 in the morning, our medic 121 was called over there for a patient with concern for stroke. So stroke-like symptoms is what the phone call came in from, or for. As I said, it's a rehab facility, so the folks that are calling, that are activating 911, obviously do have some medical training. So they know what they're looking at. They identified this and called us. The staff reports that they saw this patient in his room at 6:25 and that he was well in his bed. A few minutes later, they report coming back into the room, and he was on the floor. He had attempted to transfer himself to his wheelchair, and he fell during that. They noted that he had slurred speech at the time, and again, they immediately activated 911, calling us to the scene because they were concerned for that. I will tell you that the history that I referred to is that he had a recent left foot amputation, and that's what he was there for rehab for. So that 911 activation happened. We responded. We were there within a few minutes, our medic 121. And again, this was last minute. So what I would have loved was to have medics standing up here talking about this scenario, this situation. But because of the timing, we didn't really have time for that. So I am doing my best to present to you what they saw when they went, okay? So this gentleman, they found out quickly when they started doing their assessment that he had a history of hyperlipidemia, hypertension, previous DVT as well, type 2 diabetes. Feels like I'm missing something. No, I think that's it. He was on a variety of medications, including Eliquis. So we know, obviously, that there's obviously going to be some concern there. We know he's on Eliquis. He's on a couple or at least a beta blocker, glipizide. So he's on a variety of different medications. The crew recognized that. They noted quickly that there was chief concern for stroke, as the staff had called them over there for. I had a couple of slides. Did we not get all of them? That's all right. I mean, I can continue to talk about it. So their assessment.
Hold on. Sorry.
Oh, you're good.
You've got somebody up here who is.
Yeah, perfect.
I'm sorry.
No, you're
not
fine.
Used
You're
to
doing
this.
great. So again, slurred speech, fell when transitioning. You can go to the next one, please.
Okay.
Yep. So their assessment revealed he was alert and oriented. His airway and breathing are okay. All right. He denied having a loss of consciousness. They did note that he had left-sided facial droop, and that he was, from what they could tell, he was slurring his speech. He also had, when they checked his extremities, he demonstrated some left-sided extremity weakness, if not drift, there on the left upper extremities. So they noted that very quickly. His vital signs were fairly stable. His blood pressure it was really kind of unremarkable at 141 over 90, 96, 98. I say unremarkable, that's obviously not the highest blood pressure you'll hear if you have concern for somebody having a stroke. His blood glucose was 81, so they did test his blood sugar, okay? They noted that he was positive for our Cincinnati stroke scale with the symptoms that were previously described, and they identified his LAM score, his Los Angeles Motor Score, as a 3. So there was concern for a large vessel occlusion, okay? They called a code stroke quickly to Barnes St. Peter's, being the closest appropriate facility that we could transport rapidly to. And again, not being on scene, I don't know necessarily what the request of the patient or the facility was, but it likely went, hey, we're going to go to Barnes St. Peter's. You guys are good with that, right? Because again, being the closest appropriate facility. And then that's what happened. So then they transported to Barnes St. Peter's. He was on the monitor. They started an IV and then gave a report to Ashley when they showed up at Barnes St. Peter's.
I'm going to let you hand the microphone to Dr. Ebi in case he needs to answer some questions.
You also have that little slide clicker thing.
Yeah, I know. I'm more comfortable doing this. I'm going to take over and kind of present what happened at Barnes St. Peter's. So as you can see, his ED arrival was at 6:56, and we already heard from John that his last known woe was at 6:25. So this all happened in a relatively short period of time. So his stroke screening upon arrival was positive for a variety of things, almost everything he was positive for. And then John already kind of reviewed his past medical history and known stroke risk factors. So his total NIH was a 14, and at Barnes St. Peter's we do have some stroke measures or metrics that we like to monitor, so we kind of know how we're doing. So we have a goal for a door-to-provider evaluation of less than 5 minutes, and our team met this patient at the door as they came in at the stroke stop. Our stroke activation, code stroke activation after that was 8 minutes. It occurred at 7:04. And then our door to CT done, we do have a stretch goal at Barnes Jewish St. Peter's for less than 15 minutes. It's about 5 minutes lower than what the AHA recommended goal is, but you can see that we even beat our stretch goal, and we had his CT done in 12 minutes. And then another component that we measure in partnership with our telestroke partners is a door to telestroke start time. Our telestroke director would like to have that done within less than 30 minutes, and telestroke was on his case within 23 minutes of arrival time. So Dr. Ebi assisted me in making arrows to point to the correct things on these images. So you can see that his non-con showed a right temporal acute intraparenchymal hemorrhage with a small subarachnoid component, and we're going to put a little asterisk with that and talk about that later. The middle image shows a dense MCA sign in the distal M1 and proximal M2 segment, and then on the left here you can see that he has a complete occlusion of the M1 segment of the right MCA, and that is his CTA. Normally we also have perfusion pictures to go along with that. For this particular case, the perfusion measurements could not be obtained because there was an injector failure during that study. If anybody has any questions about what a dense MCA sign is or something like that, we can let Dr. Ebi answer those. Otherwise we can move right along. Okay. So it's treatment decision time. All studies were completed by 7:21, and then our thrombectomy activation went out to our on-call team at 8:18. That seems like a pretty long time, right? So what took so long? Well, we talked about how we suspected that this patient had a component of a bleed as well as an LVO, so that made him a very atypical case. And we always review our cases and we dive deep into them to see what were the delays, what could have been done differently. So some of the delays in this case was we had some delays between imaging done and ED release to our NIR suite. And that was related because there were extensive conversations going on amongst all the team members. Our ED doctors were involved, our NIH or our NIR provider on call was involved, our telestroke doctor was involved, and I believe our on-call provider for NIR was also reaching out to other NIR physicians to make the best decisions, if I understand that correctly. So a lot of extensive conversations. Then they had to have a conversation with the patient and explain to him the risk and benefits of this procedure, because with him having a potential bleed, he basically was told on the phone by our physician doing the procedure that he had a 50% chance of dying on the interventional table. So we don't usually tell our patients that because it's not, I think, usually that grave of a risk when we take our patients for thrombectomy. So a lot of conversation. So I think it's fair to say that was a good reason for delay. We wanted to make the right treatment choice and give the right information to the patient so he could make the right choice for himself. Also, we heard that the patient had been on Eliquis, so he did need some reversal before the procedure. And then finally, kind of in the days later, we discovered that there was some Everbridge paging issues, which is the system that we use at Barnes St. Peter's to send out our alerts to our on-call team and to everybody else who needs to know that a thrombectomy patient is going, so we can all prepare for him or her.
Hey Denise,
Yes.
can you talk about how long or somebody talk about how long it normally takes for a reversal with PCC?
I'm good.
Sure. So, and I can talk more broadly about many of these topics if you'd like, but specifically for intracranial hemorrhage, obviously the concern is you can have ongoing or repeated hemorrhage in the area. That's actually one of the major areas of disability. Obviously, the first hemorrhage causes damage, but depending on the study, 50% or more of people come on with intraparenchymal or intracranial hemorrhage can have hematoma expansion, and that's an independent poor prognostic indicator, basically, that causes a lot of worsening. And so we try and think of the ways that we can prevent that, and one that we've all settled on and is reasonably data-driven, although we haven't really enrolled people in trials because we feel like it's unethical, but that's mainly to reverse blood thinners. It makes sense if their blood is thin, then reversing the blood thinner can help prevent more bleeding. But right now, I think we've kind of all accepted that it would be unethical for us to not reverse a patient, and randomize them to control arm. So there's actually a little bit of a debate there, but in general, we all agree that reversing the blood thinner and as soon as possible is helpful. PCC, the brand name I think we use is Kcentra. It's prothrombin complex concentrate. Before it came along to reverse anticoagulants, like especially warfarin, our options were really limited. We could give FFP, fresh frozen plasma, which is a blood product. You'd have to call it up from the blood bank, cross-match it, and infuse it, and even if you're pushing it fairly rapidly, you're talking about half an hour, and that's if it's thawed, because a lot of times it's frozen, and so you're waiting like an hour to get it thawed enough so you can push it through an IV. Or you could give vitamin K, which takes days to work, because they have to the whole way that warfarin worked was it depleted the body of a number of the coagulation factors, and so your body has to build it back up. So obviously, neither of those are really that helpful in the acute setting. Prothrombin complex concentrate is a number of factors, basically just dried that you can reconstitute. They're 3 and 4 factor PCC, and it is literally minutes. You can reconstitute it at bedside, or pharmacy can do it, and then you can essentially slam this in, and you can reverse people much better than those other things that we used to. So this has actually only really been on the scene for maybe 10 years or so. It was the hot new thing when I started my training, and it was very expensive, so they were a bit reluctant, but we consider brain bleeding one of those critical bleeds, so we started using it a lot. And now we found it's essentially standard of care. Basically any kind of, and the nice thing about it is it doesn't matter the anticoagulant at this stage. So warfarin or the newer ones, Eliquis, Pradaxa, they all seem to respond reasonably well. Some of them, Pradaxa has its own reversal, so you could consider giving that. There was another reversal agent that was actually just recently pulled from the market because of thromboembolic complications. So with any of these, one of the risks is that you reverse too much, and then it's a pro-clotting rather than an anti-clotting environment. But specifically to your question about the PCC, it's been a real advantage because this can be just a couple of minutes bedside to reverse somebody.
So this is just a display of a type of slide that Dr. Ebi and I use to review our EVAS cases, both with the BJH system and locally here in St. Charles County. And the bars just kind of give us an indication of what our timing intervals are. And so we kind of already discussed those purple bars are shared metrics between our ED and our NIR teams. And that's how we kind of delve in to find out, where the delay was. So that's just a different kind of picture that we use when we are reviewing our cases. So our procedure metrics. Our procedure team likes to have a metric that they can control. And so we developed a metric for them for thrombectomy page to NIR room arrival, and their goal was less than 45 minutes. And in this case, they were 49 minutes. Door to groin puncture time is less than 90 minutes. We were at 155. Puncture to reperfusion time, our goal is less than 60, and we did do very well there at 18 minutes. And then door to reperfusion time total was 173 minutes. And of course, each of those delays kind of plays back into those purple bars where we had those extensive discussions and things like that. Those were unavoidable, uncontrollable type delays. So, but we have some intra-procedural images, and with Dr. Ebi's help again, he helped me put arrows in the right places. So the far right is our pre-procedure, and then on the bottom is our post, and then a different view pre and post procedure. So in this case, he had a Tiki 3 recanalization, and it occurred after a single pass aspiration thrombectomy. So does anybody here know what a Tiki 3 means when it comes to reperfusion? Dr. Ebi does.
It means thumbs up. Tiki 3 is 100% recanalization. So that means that we have reperfused the whole tissue at risk.
Right.
There are step downs from that 2B or 2A, which imply there's still some residual thrombus or you haven't reperfused everything. But Tiki 3 means that you opened everything up.
Right.
So that's the ultimate goal.
Yeah, and a successful procedure is a Tiki 2B or greater. So this was a very successful procedure. And then his outcome, the patient outcome, he was transferred directly from BJH from St. Peter's Vic Lab at the conclusion of the procedure because there was concern for the IPH hematoma and risk for expansion. And then they completed a stroke workup at Barnes Jewish BJH. Special kudos to our ED team. Usually once the patient passes through their doors, they don't have anything else to do with them, but our ED team did assist in facilitating in the patient's transfer. Our pre-procedure NIH for this gentleman was 14. Our post-procedure NIH at St. Peter's was 7, and by the time he arrived to Big Barnes, he was down to a 2, so that's pretty amazing. On hospital day 3, he was transferred out of the Barnes Jewish ICU, and he had an NIH of 0. And then he was returned to St. Peter's Rehab and Healthcare Center on the 3rd with an NIH of 0. It looks like they suspect he had an embolic stroke of undetermined source, which means with all the workup, they could not find a cause for his stroke. And they did resume his Eliquis on day 5. Since he had that history of chronic DVT. And then at the beginning, I said we were going to put a little asterisk by that ICH. When we did our EVASC review on this gentleman, the provider who did the procedure said after further review, it was determined that the patient did not have a hemorrhage, but rather it was a gliosis, which still would have required special considerations prior to a thrombectomy decision. So I would have to let Dr. Ebi explain to you what gliosis is.
You want me to now?
Sure.
So after getting the MRI scan, in retrospect, it looks like this is actually essentially scar tissue. So gliosis is the process of the brain scarring down, typically after a stroke. And this cortical laminar necrosis is just a way in which the cortex, hence cortical, necrosis or scars down, breaks down the tissue, usually implying at the very least like late subacute, but this is usually a chronic appearance for a stroke. So, the implication here is that he didn't have hemorrhage in that region, but he had an old stroke that scarred. That becomes really tricky, obviously, because if he had kind of a subacute stroke in that same territory, that becomes difficult to know, should you do thrombectomy, are there increased risks as well? But I think the point here is that would have also been essentially impossible to tell from the head CT,
So, in conclusion, our key takeaways, stroke metrics are important. Sometimes we get focused on the numbers, but they only represent part of the overall picture of our stroke programs. We realize we will not meet every stroke metric in every case, but our target allows for nuances and unique circumstances such as were present in this case. The patient's safety and clinical outcomes will always remain top priority for us. However, every case, even the ones who go exceptionally well, presents opportunity for learning and for continuous improvement. And then finally, this patient's outcome demonstrates that teamwork across the entire spectrum of care, from pre-hospital to discharge and beyond, is essential in achieving timely recognition, appropriate intervention, and the best possible results for the patient. So, with that very impromptu case study, I hope that you learned some good things. If anybody has any questions.
I have a comment about that.
Yeah.
I just wanted to say that they presented this to me and said, hey, we should celebrate this case. And I was like, great, let's do it. And then because of the situation we found ourselves in, last night I was reading our EMS charts, and I'm like, oh, this is really interesting and something worth us paying attention to. And that is, what I mean is, Denise said, and I think absolutely it is a key takeaway, is our assessment in the pre-hospital world, obviously not only from the assessment, them figuring out the medications that he's on, identifying that he's on Eliquis, letting the team know that, calling the coach stroke, we know we're going to go transport to an appropriate facility. Barnes St. Peter's is ready for us when we're coming. But again, we spent time talking about the delays, but this also for me was really remarkable because this gentleman had an amazing outcome. Mm-hmm. And that really has everything to do with the teamwork that happened on this call. So I just want to make sure that we're all, we talked about how last minute this was, but this really is something to celebrate, and I think it's a perfect opportunity for a symposium like this because we're really talking about stroke methods of care and our stroke system and how we try to do the best thing for patients that have stroke symptoms. So
right. And one of our partners who supplies thrombectomy supplies for us, the provider who did the procedure reached out to them and asked them that to make some posters to celebrate each of the teams, including SCCAD. I have one for our Vic Lab. I also have one for our ED. It kind of gives a little synopsis of the case, and it gives the team members who touched this patient, and including those who transported the patient from Barnes St. Peter's to BJH, because it truly is a celebration that this patient is doing so well. So oh, yes, you had a question?
Yeah. So I guess this is two parts. So you have your time markers and you didn't beat them out. The patient did very well. So did they do well because you took the extra time, or did they do well in spite of taking the extra time? And then on the flip side of that is, say you would have met your markers and made like rapid decisions without the consideration, would that patient have gone worse off? And if they would, what would that look like?
That's a great question. I guess I can talk from a physician standpoint, but I think this highlights a lot of points. And so to answer your question, I think you need to look at it two different ways. One is with the information at the time, and one is in retrospect, right? Because now we know that the situation is a little different than we first envisioned. In general, this patient did really well, but I would say that's probably despite having some added delays, right? Because ultimately it seems like thrombectomy was the right decision. He responded well to it. And so in that regard, I wouldn't have said that going faster would have hurt him in retrospect. The problem is, at the time, we didn't know what was going on. And by rushing and not taking some time to talk about it, we really could have put that patient in a position where we were hurting them instead of helping them. And so this is one of those ones where it's really difficult. We focus on the good metrics, but it is a win, I think, to give a patient treatment despite not having good metrics. And the contrary to that would be, there would be a real consideration for a scenario in which somebody comes in, we see a bleed on the scan, you have a group that is not as diligent to, really work up that patient and think about what's best for them, and very quickly says, no, too high risk, we're not going to do it. I see a bleed, automatically exclude. Maybe they don't even call the interventionalist, I don't know. And that's a scenario in which that patient never goes for thrombectomy. And their outcome would have probably been much worse. But the times would have looked great. They would have showed up, we would have gotten the scans, they never would have gone to the thrombectomy, so we would never have to say there was a delay to puncture, where too focused on kind of the protocol and the times can hurt us. Since I have the mic, I just want to point out a couple of things that I think are really instructive about this case and helpful to kind of delineate some of the difficulties and how it really is a teamwork on all pieces here, right? So when you see a patient in the field, and you bring him into the hospital, you have no idea if it's a bleed or a stroke, or in this case, a combination of both. And when I say stroke, I mean ischemic stroke, a blockage, right? But for both of them, time can be of the essence, right? And so, we have some screening tools to get an idea of severity, but, still getting them to the right place and getting that head CT early is the crucial part, and that's the whole idea behind the mobile stroke units that you guys might have seen some stuff about, like can you bring the CT scanner to the patient, and that's its own cumbersome thing. But but then there can be some nuance there. So just because of LAM score, we were saying that this looks pretty severe, and we brought them in, and then we identified this potential bleed, and we were able to act on that very quickly with the PCC. Now that bleed isn't that large, this patient is really quite disabled. Well, this is kind of the nursing protocol at St. Peter's ER. We've developed an algorithm to allow for the code stroke process to kind of develop without somebody having to push each button along the way. And so we knew this patient was a high LAM score, we knew they were a high stroke scale, we wanted to get that CTA CTP. And what that also showed us was the large vessel occlusion, because in another environment, they might have come in, got the head CT, saw a bleed, and then just stopped and said, well, we have a bleed, that explains it. But this probably doesn't show the whole picture of this patient. And in retrospect, it clearly didn't, right? He was having a very large blockage stroke. And so because we were able to facilitate that quickly, we were also able to identify the LVO. And it was only after all that data that we were able to sit, as academic neurologists and interventionalists to really delineate, what do we think is causing what do we think the risks are? And then that was by far the most difficult part, right? But it required a very well-oiled machine to be able to get to the point where we can have a high level of discussion. And so it was my partner that did this case in full discussion, but I think it was like a Saturday morning, and I can't really remember exactly what it was, but we have like a attending group thread, and he fired out in the group thread. He was like, there's a patient with a bleed and an LVO. Do you guys have any experience with this? How do you consider it? Because this would have been excluded from all of our trials, right? Like they would have said, we don't want to do that. Maybe because it would or would not help. I mean, there's risk of opening up this artery into an artery that is bleeding. You can make it worse. But also because it's messy. So when you're doing a trial to prove opening an artery works, you want really the only thing that's going on with that patient to be the blocked artery. And so, we just don't have data. So we were both on PubMed scrambling for articles. I was like, here's a case series of 12 patients, and he found a separate one from a similar group. And that's where we got this, estimate of a 50% mortality. Now, when we're in these kind of odd situations, a lot of times we kind of inflate the risks a little, but that was actually fairly accurate for the small numbers that were reported. But we inflate the risk in the sense that like, we want people to take it seriously, right? Like we're not just gonna do this glibly. But in that same regard, if we had left this, there was probably at least a 50% chance that that guy was gonna be permanently disabled. And so, that's the flip side of the coin. And so we had a conversation, and basically, we're able to have that conversation with the patient and his family. But in our estimation, that bleed didn't explain his symptoms. The large vessel occlusion did look like it. We know thrombectomy works in other situations, so we were willing to offer it. And with all of that on board, then you still fire up the same teams and the processes, the Vic lab, grabbing this patient, we still went quickly. And so we were able to open this artery really quite quickly, and he ended up having a good result. And so, we had to lean on every single team working quickly to be able to do this much, in what ends up being a short amount of time, despite what the metrics would try and tell you. So, this was a really complex case, and it required everybody hitting, their target so well.
Follow-up, is it fair to say then, like, because when we get these ambiguous cases in the field, you'll see that we'll spend time to deliberate, like, hey, what exactly is this? So is it fair to say that if the time window is this much for a good outcome, and we separate with pre-hospital time, hospital time, ER time, and so on, that really, on the pre-hospital side, unless we definitively know that our interventions will make a difference, to shorten that time frame so it affords you more time on the hospital side to delineate and make those decisions. Would that be fair?
Yeah, and I mean, I'll leave the specifics to your medical director, obviously, but in general, I think that's reasonable logic in the sense that, I don't think it's necessarily your job to figure out exactly what's going on with that person, but I do want you to have suspicion. And so if you think it's stroke, let us know ahead of time. And this is going to be kind of part of my whole talk for posterior circulation strokes, but we want you to cast a broad net. And so think about stroke, include that in it, and put it through the code stroke. And then, once you get them in, we can kind of try and sift through the rest of it on the back end. But, if you don't call it out ahead of time, then we're not thinking it, and we're kind of working backwards up that chain. But for, many of these things, yeah, it's, obviously acute stabilization is important, but there's not a lot of medical, management that needs to happen before they hit the door. That has to be kind of decided after we get the CT scans and figuring that out. And so, getting them in quickly would be helpful across the board, I think.